So I've been asked to talk about the urinary microbiome and prostate disease. Well, I'd much rather talk about what we're doing in the realm of urinary tract infections and our understanding of what's going on with urinary tract infections in the microbiome and how we're actually winning the battle with new vaccines. We just published our vaccine article in the New England Journal of Medicine. It's going to be a game changer. It's a little bit different for prostate disease. We're a little behind. So what has changed everything? Well, it's the state-of-the-art next-generation sequencing and PCR that we talked about before. We now understand that the urinary tract is not sterile. It's a microbial jungle. Now, I have to tell you what's happening here, because you don't see any pictures of bacteria. What you're seeing is different figures that you can't understand, and I probably am going to have trouble explaining it because I don't understand some of these that well. What I want you to, when I present some of these, what I want you to do is look at them as scientific art. Look for patterns and colors and explore what I'm trying to show you. Look at the beauty of what's going on in the microbiome in scientific figures like this, and I'll try and take you through it as somebody who takes you through a museum, an art gallery, and looking at this. So we're presented in September 2021 looking at the normal male and female microbiome. And what we found out, always before, we believed there was a core normal microbiome, but there is not a normal male core urinary microbiome. If you look at your left, you'll see that all those 100 patients, every one looks a little bit different. You can see on the right, we tried to put them into categories, and there are 3 categories, but the only category that really is tight is that we call community state number 2, that the one in the center with all the purple, and that's primarily E. coli and others. And then you look above it, and you can start to see that the different groups are so overlapping. There is no such thing as a normal male microbiome. It's dependent on your age, your genetics, your geography, your diet, probably what books you read. I'm not sure. So it puts us in a bit of a state when we're looking at men in the microbiome. Now, I've been very interested in prostatitis. That's where I started my career, and that's where I'm sort of ending it. It was to find the Helicopylori of prostatitis, which I will never find because I believe it's elusive because it's not there. Instead, what we found is in bacterial prostatitis, we found these bacterial biofilms. These are gram-negative and gram-positive biofilms deep within the prostate gland of patients who have recurrent urinary tract infections. They're extremely hard to disrupt and get rid of, and you have to determine the exact right antibiotic, high enough concentration to get in the prostate, and even then you may get a recurrent urinary tract infection from this nidus infection deep in the prostate. This is the 8% of men with chronic bacterial prostatitis. What about the others with chronic prostatitis, chronic pelvic pain syndrome? Well, we published a number of years ago a NIH study with a MAP study looking for that Helicopylori. We thought we found it, and it was B. Senocepetia, but it wasn't. This was a bug that showed up, but it wasn't enough frequency to say this is our bug. And in fact, when we started looking for this bug in further studies, it didn't show up quite as much as we thought. So last year we presented, well, it's actually only September with the virtual AUA. We looked at 2,404 patients with chronic prostatitis with an ICD diagnosis, compared it to 334 males with acute cystitis and 105 healthy control males, and looked at their urinary microbiome, midstream urinary microbiome. And we were able to detect over 500 different genera representing thousands of species. And the 5 most abundant genera, I guess what we'd expect, is staph, Escherichia, strep, Enterococcus, and Corynebacterium. But what's interesting, is the blue here is Staphylococcus, and the purple is E. coli. So you see, even in healthy individuals, we see a small percentage of E. coli, Staphylococcus, Streptococcus, more so in the acute cystitis, as we expect, primarily E. coli, and in the prostatitis, more than what we'd see in the control. So we were seeing some patterns here. When we looked at alpha diversity, we found that the diversity between the samples was non-randomly distributed with higher diversity in the healthy individuals. That's what we thought, but you can see there's almost a bit of an overlap if you look at the diagram on your left. When we looked at the 47 genera that were different between prostatitis and acute cystitis, and healthy controls, we did see that there were bacterial lineages, as many as 47 different groups that could be potential differences. But as I said, we couldn't pick out one that was the major difference. And that's because when we look at this microbiome composition, we see three main groups, the prostatitis, the acute cystitis, and the healthy. And you look at the overlap, there's a huge overlap. And this year we thought, okay, the problem is maybe that ICD diagnosis had too much, maybe garbage diagnosis in it. So this year we're going to be presenting at the AUA a similar study, just looking at those with a clinical diagnosis of chronic prostatitis, 763. By the way, if you're in general practice, you know that that's a heck of a lot of prostatitis patients to get anywhere together. Asymptomatic healthy controls, 92. And we were able to compare them using the same type of differential analysis. And again, if you look at the patterns, you can see there's different patterns between the left and the right, no matter whether we're looking at the different diversity between chronic prostatitis and healthy controls, or actually looking at the abundance of the bacteria. They're different, yet there's so much overlap that we have a lot of, sort of the same problem you have with a PSA of 4, that we have with the microbiome. So in the summary with the prostatitis, we have a subset that may be related to bacterial infection because they look like the acute cystitis patients. B. Senocepacia might have been a candidate organism, but we weren't able to replicate that using different techniques. We saw E. coli, Klebsiella pneumonia, C. acnes, and this other bug that I'm not sure how it's involved, but those four were the candidate bacteria. But again, not in all the patients, and it only described the variation in a small percentage. There was a different components of variation for alpha and beta diversity. So what we think is happening, that instead of one bug, it might be a couple bugs working together that increases the inflammation and or the symptoms. But the only way we're going to be able to determine whether this is important is outcome studies, where we actually study and eradicate these bacteria in the prostate and see if the patients get better. What about BPH? Well, we know in BPH, and this is from the REDUCE study, that chronic prostate inflammation is associated with the severity and progression of BPH, lower urinary tract symptoms, and the risk of acute urinary retention. In other words, inflammation in BPH is one of the key factors that drives the disease. We also see that if we look in the microbial population, in prostate secretions, voided urine, and seminal fluid from patients' diagnosis with BPH, we see there's differences when we compare them to prostate cancer. What does it mean? Not sure, but we know that we get, in men with LUTs, usually BPH LUTs, we get an increasing severity of LUTs, and that's that yellow line there, associated with bacteria. And it's quite obvious the more different types of bacteria we can actually look at this. So where are we? Well, what's intriguing with BPH and male LUTs? We've got many questions. Which bacteria are important? Are there multiple bacteria? Are there bacterial interactions? What is the impact of those abundance patterns? And is it a cause or effect? That's always been a problem. We don't have a lot of answers. Nothing's confirmatory, but there are a lot of clinical laboratories across the world looking at this right now. And finally, I'll end with prostate cancer, because as we know, there's a clear evidence of an association between inflammation and colorectal malignancy, as well as in gastric and hepatobiliary cancer. We know the bacteria can modulate cancer risk by doing all these mechanisms of actions in animal models. So the simple thing is that we get infection in the prostate, we get inflammation in the prostate, and we end up with early and then progressive prostate cancer. If only life was so simple. The question is, do the bacteria or how the bacteria contributes to the pathogenesis of prostate cancer. And people a lot smarter than me have made wonderful diagrams to try and figure out what is happening. This one is basically the bacteria are floating around, they adhere, and they use all those mechanisms to cause a tumorigenic environment. Now, this is the type of picture that I see, a figure that I see a lot at prostate cancer meetings. Uninterpretable. You can't even figure out what's going on, but there's arrows everywhere, and there's big names, and it's kind of an exciting thing to follow through. I dare anybody, I'll give you this, and I'll give you half an hour, and you try and explain what's happening to me. But I have always wanted to present this type of figure at a prostate cancer meeting, because it does make me feel pretty important. I just wish I knew what it meant. But the people that think they know what it means is this is how bacteria promote prostate cancer. However, simple-minded as I am, I put it together, and this is what I think is going on. I think it's, you start out with your genetics, your diet, your environment, and yes, antibiotics. Antibiotics are not good for your microbiome. It causes all sorts of dysbiosis and abnormalities and pollution in our system. And these things impact the gut microbiome and the GU microbiome. The gut microbiome, from everything from chronic inflammation, LPS-induced inflammation, interrupting and skewing the immune system the wrong way, altered metabolism, all those things indirectly impact not only the GU microbiome, but the prostate itself. In the GU microbiome, same thing is happening. Dysbiosis in the prostate, we may get procarcinogenic products, oxidative stress. We may even have an interaction between the bacteria and the viral microbiome. And in the prostate, we end up with an environment that can induce early prostate cancer. So what's actually happening when we look at it? The best studies are either looking at prostate fluid or tissue. And what you see is these are the 5 main studies in the last couple of years. There's going to be many more, and I know there's going to be more presented at the AUA. And what you see is not really a major pattern. You see somebody finds Helical pylori. That's what's causing prostate cancers. Others see that E. coli and Pseudomonas might be involved in it. You already heard earlier in his abstract show that in his and David Crawford's, and I was a bit involved in that, where we saw C. acnes is a possible player in this. We can also look at sort of indirect gut PCR NGS studies, and these are studies done over the last several years that suggest certain bacteria in the gut may be promoting tumors in the prostate gland. Well, the latest study actually found no difference from BPH. Viral studies were really thought to be what was important a decade ago or more. However, nothing much has been done since the the virus story in the Epstein-Barr, the BK virus, the cytomegalovirus, all those thought to be important. But we do see, and that's what's important, a differential microbial abundance in prostate cancer compared to BPH. Higher numbers of E. coli and Enterococcus in prostate-related fluids. However, is it cause or effect? Is it secondary to biopsies? Is it secondary to antibiotics? Is it secondary to radiation therapy, hormone therapy? So Prior already presented this, and this is a paper that we presented, or David Crawford presented at the AUA in September, showing that there did appear to be a different pattern in prostate cancer with 2 bugs rising to the center. You already saw this slide. C. acnes associated with prostate cancer and is a pro-inflammatory type of bacteria. Well, F. magna associated with a low-risk control group is associated with soy isoflavone intake, which is thought to reduce prostate cancer. So this may be very important. It certainly has to be followed through. And I think primarily the next step is going to have to be sophisticated tissue cultures. So the prostate cancer microbiome is going to be one of these 2, or actually could be somewhere in between. Bacteria in the prostate promotes the development and progression of prostate cancer. That's what I'd like to see because I'm involved in the field. The proof is not here yet. Or it could be prostate cancer, or the diagnostic testing, or the radiotherapy, biopsy, hormone treatment alters the prostate microbiome, and that's what we're seeing. Or it could be somewhere in between. What it is, it's complicated. So when we look at the issues that I've raised between this male urinary microbiome and prostate disease, we start off by saying I don't believe there's a normal, core, normal male healthy urinary microbiome. I think if we went around here, we'd find that most of us would fall into one of those three: community state or urotypes. But if we went to Chile or Argentina or sub-Saharan Africa or Asia, I bet you we'd find different community states or urotypes of bacteria. There is an association between male LUTs, chronic prostatitis, and BPH, and this dysbiotic microbiome. In other words, there is a different pattern, and that's what you could see in those figures, but no causative organism that we can pick out right now. There is an abnormal prostate microbiome associated with prostate cancer, but it's complicated, and we need to determine the cause and effect of this. So this relationship between prostate disease and the urinary microbiome is intriguing, it's exciting. I really wish I was a decade or two younger, because this is a place where careers are going to be made, because it is going to be important. Much more work is required before we even find that smoking gun, whether it is a rifle with a single bullet, which I doubt. I think it's more likely going to be a shotgun. So I think, and I got my fingers crossed, that this field, which is in infancy right now as far as prostate disease, over the next 5 to 10 years, it's going to explode, and we're going to understand more about our own urinary microbiome and its association with prostate disease. Thank you very much.